Okay, today we will be talking about physical impairments and health conditions with a focus on physical impairments. So we want to make sure to separate these two categories, even though they can occur simultaneously. So physical impairments relate to any problems involving the skeleton, the joints, or the muscles. And there are children that can have involvement in all three areas. And then you have children that have just an isolated issue. So either just with the skeleton, only with their joints, or only with their muscles. Okay? This category also includes children with conditions like missing limbs, any kind of diagnosis of club feet, hip dislocations like hip dysplasia also is categorized under physical impairment. Even though cerebral palsy is a neurological disorder, because of the physical characteristics that are associated with cerebral palsy, it can also be listed under physical impairments. Okay? We also know that children who have temporary injuries like fractures or burns can also be categorized under physical impairment because it's going to affect how they function in the classroom. And then children who have amputations and then have prosthesis afterwards, even though cognitively they can function like a typically developing child, their amputation and their prosthesis might make it so that they need some kind of accommodations and adjustments to the classroom environment. Okay? When we talk about health conditions, when a child is experiencing a chronic health condition, it limits their strength and vitality. So you often see children who are overly exhausted or overly tired in the classroom. Maybe they're so drained that they can't make it to the actual classroom. They're on maybe so much medication that it's hard for them to focus and stay alert. So you see them kind of dozing out or kind of dazing off. So some of these problems can be heart conditions, so either a significant heart murmur, HLHS is a common heart condition. Anybody know who Colin Kaepernick is? Any Niners fans?
Yes.
So Colin Kaepernick actually is a big contributor to the HLHS Foundation. It's called Camp Taylor. It's a pretty severe heart condition where the ventricles of the heart are switched. And so most children, when this condition first started appearing, weren't living very long. They were dying really early, if they were even born living. Now we have children, because of all the technology, we have children living all the way into adulthood. I have a nephew with HLHS, and he's going to be 19 years old. But because of his heart condition, he has short stature. He's not allowed to fly because of his heart condition. The pressure could be fatal to his heart. And when he was a child, he had a really tough time in school, not cognitively. He's so bright, but socially, because he was a lot smaller than a lot of the kids. So some of those accommodations and adaptations had to be the facilitation of social interaction. That's something we need to think about too with children with health conditions. Also looking at things like epilepsy. So the one child that I worked one-on-one with, as a paraeducator, she had epilepsy, and her condition actually caused her to lose her vision in one eye. Her kind of epilepsy the seizures would be prompted by sunlight, so she had to remain in the shade. She had to wear specialized glasses as well so that it didn't prompt a seizure during play. Children with chronic asthma. So if you're familiar, or you know somebody, everyone tends to know somebody with asthma, especially living here in the Central Valley. And some of these children are out for months at a time because of asthmatic conditions, and they're hospitalized and they're on breathing treatments. And so it might not necessarily be adapted material that you're creating for these children, but it might be adaptations to how much energy they're exerting during physical education, right? So those kinds of adaptations to curriculum are things to consider. Children experiencing leukemia, diabetes, sickle cell anemia, HIV and AIDS and hemophilia, those have specific medications that really change the dynamic of the child's character. So you see children who are often really just kind of sick and nauseous a lot. They're tired, they might be a little bit anxious. And so supporting children in the classroom or program environment when they're feeling that way under that medication. And then you might not think of obesity as a health condition, but when a child has too much body weight, so the body mass index is really high, it impairs their ability to focus, it impairs their ability to sit and attend. It also impairs their ability to engage in social interactions appropriately. I want you to think about what sugar does to your body. It might give you a rush, but then what happens when that sugar wears off?
Goes down.
Yes, you kind of get regress a little bit in your energy. And also your body is then craving more of that sugar or more of those carbs. And so it's almost like an addiction where you're kind of more easily irritated, you're kind of on edge. And this is what's happening with children who are experiencing obesity. Okay. So two different conditions, physical impairment, health conditions. All right. So cerebral palsy specifically, we're going to discuss some of the vocabulary that's associated with cerebral palsy because it is the most common physical disability in children. There's varying levels of severity with cerebral palsy, and what's really important to know is that it's neurological, but it's in the motor center of the brain. So children with cerebral palsy often function at a typical development cognitively. So they're just as smart as a typically developing child, but because those motor neurons are impaired, the way that they're able to speak or move their muscles in their mouth might be impaired. And so often people who aren't familiar with the cerebral palsy diagnosis might look at the way that child talks or moves and assume a cognitive impairment. I beg you never to assume a cognitive impairment. It's really kind of insulting to children to assume that, and to adults with cerebral palsy. Okay. Damage can occur before, during, or after birth. A lot of times I see children born with cerebral palsy when they had to use forceps during delivery. And so what happens with forceps is the forceps are usually placed either around the child's head or around the fetus's shoulders, and then the baby is pulled out of the vagina. And what happens with that is we know how malleable the baby's head is, the baby's skull is, it's not fully dense. And so any pressure can cause some significant damage. And so that's where we sometimes see the cause of cerebral palsy. Okay. We often will see signs of cerebral palsy, but we might not see how severe it's going to be until age 5 years old. So I'll give you an example. I worked with a little boy. He was just only referred for speech delay. And so I worked with him. It was a Spanish-speaking family. I worked with him from the time he was 1.5 years to 3 years old, and he did great. His speech caught up to age level. He had some little delays with his fine motor, but nothing significant or to warrant a red flag for any further therapy. And so by the time he got to kindergarten, his mom called me and said, "You'll never believe it, but he got diagnosed with cerebral palsy, but it's so low in severity that he's able to function fully in school." But just so happened a physical therapist was working with him and noticed that he had characteristics of cerebral palsy. Just so slim though, they didn't see it. He was about 5 years old. Okay. So familiar or common characteristic of cerebral palsy is called spasticity, also known as hypertonic muscles. Okay, so you're going to learn about hypertonic and hypotonic. So spasticity is hypertonic. And these are muscles that flex have higher muscle tone than the muscles that extend the joint. So it often looks like these images right here. And what it does is it makes it difficult to unflex. So it's so tightly flexed that the energy that has to be exerted in order to unflex often wears children out, which is why children, after maybe 5 minutes of exerting energy, often get really tired. And it's because they're having to put so much energy into just doing simple movements that children who are typically developing kind of do without really thinking about it. Okay. I do have a video here that I would love for you to watch. It's an example of a child with cerebral palsy hemi. So that's hemiplegia. Only half of her body is affected by cerebral palsy. And so you'll see some of this spasticity in her arm. Her arm is held up tight, and you'll see that her leg has a little bit of trouble bending as well. Okay. Questions about this slide, spasticity?
No.
No.
So there's hypertonicity and then there's hypotonicity. So if hypertonicity is too much muscle tone, too much flexion, then hypotonicity is too little muscle tone. And so often children who have hypotonicity are known as like ragdoll babies, which is a horrible for them. What was that?
I said, oh my goodness, they just flopped there.
Yes, they have no muscle tone at all, or really, really, really low muscle tone. So their body kind of just flops over. If you hold them in different positions, their head flops. It's really hard for them to maintain an upright position. Sometimes it's typical for younger children to have a little bit of hypotonicity, but as they get older and build their strength, maybe it will go away. But when you see children, for example, I worked with a 16-month-old little girl and she still looked like this. So she was so hypotonic that if you picked her up, her body would just kind of flop like this. She was very hypotonic, but she also had a little bit of athetosis. So athetosis is when the muscles fluctuate between too much or too little muscle control. And what it looks like is almost like the reflex. If you've ever seen a baby kind of wake up and then all of a sudden they move their hand really fast and then they stretch a little bit. So think about a 2-year-old who's engaging in that same primitive reflexive action. And that's what she was doing. She also hated therapy, like hated anybody moving her body. She would cry every time we came. It was hard. It was really hard for her to hold her body upright. But we used her anger towards us in session to our advantage. So one of the exercises we did with her is we would sit her in her mom's lap, but sitting on the floor. So she was sitting right in between her mom's legs on the floor. And so her mom would hold her up by her waist. And we wanted her to extend and use her arm muscles because her arm muscles were just so weak, they'd kind of flop to the side. So we got this big giant ball and we'd roll it right up to her face and her hands would do this. And she's like, like, stop it. But she got so mad that one day she finally went, and she pushed it away. So she was mad, but we used that anger to our advantage. And she totally used those muscles and pushed it away. Then we just did like a silly face, like, oh my gosh, what did you just do? And she thought that was hilarious. And we kept doing it over and over. And she got stronger and stronger. Then we did the same thing with her legs. And she thought it was funny because she thought she was doing something like naughty or silly. And so, 2-year-olds, if they think they're doing something they're not supposed to do, all of a sudden it's fun. So she really enjoyed that activity. And she did end up gaining some muscle tone, but she didn't walk till she was about 3. And she, even at 3, her the quality of her walking was not great. She still needed some support in walking. She would fall frequently because she still had really low muscle tone in her legs and in the rest of her body. She ended up getting referred for genetic testing, and they found out she has a very rare genetic condition. That is what affected her low muscle tone, that hypotonicity. Okay. So ataxia, we often see in children with sensory impairment, so sensory integration disorder, or children, sometimes children with autism, but primarily we see ataxia with children with cerebral palsy. It's just kind of a lack of motor control, really poor fine motor skills. So they're not able to keep control of their pencil or their pen or whatever they're writing with. They have a hard time picking up small objects and maybe bringing them to their mouth if they're eating. It's just a struggle with that fine motor aspect of motor skills. Questions about this?
No.
So there's different ways to classify cerebral palsy, and often they're classified by the body parts that are affected. So monoplegia is just one limb, one side, one half of the body. So either a leg or one arm, but not, it's just one side, one leg. Whereas hemiplegia has the entire half of the body is affected. So either the right side or the left side is completely affected. Okay. And then, but not the head. Okay. Diplegia can be either the top half or the bottom half, but it's both sides that are affected. Okay. Quadriplegic is somebody whose entire body is affected, but not the head. Whereas total body is every single part of the body is affected. Okay. Questions about that?
No.
All right, so let's look at spinal cord injuries. We know that if a child or anyone gets injured in the spinal cord, it's going to affect any messages sent to anything below the point of injury. So we know the brain sends messages through the spinal cord. So let's say the injury is in the middle of the spinal cord. Anything below the middle of the spinal cord isn't going to receive messages from the brain anymore. We know that the brain itself isn't affected. The brain is still sending the signals, but it's almost like a block or a wall has been placed where that injury took place, and no messages can get past that wall. So what do you think happens with children? Are they able to toilet train it when they get a spinal injury?
No.
No, they don't get that message that, hey, I have to use the bathroom. There's no sense of urgency. There's no feeling of I need to hold in my urine. And so usually children who have a spinal cord injury often have to wear diapers for the rest of their lives unless they get it corrected, if it's correctable. Okay. Keep going. Oh, and then hydrocephalus. Anybody know what hydrocephalus is?
No.
So hydro is, what do you think of when you think of hydro?
Water.
Water, good. And then anything with cephaly, it's the brain. And so it's water in the brain. And it's not necessarily water, it's cerebral spinal fluid. And your cerebral spinal fluid should not be built up in your brain. And so children that have hydrocephalus have a buildup of cerebral spinal fluid that, if it's not drained, can cause significant brain damage. But most individuals with hydrocephalus, they'll get something in their skull called the shunt, and that shunt, what it does is it drains the fluid out of their brain back into their spine, and then those individuals are able to function completely typically, with the exception that they can't do contact sports, because if that shunt is ruined at all, they can have significant brain damage. Okay. I didn't cover spina bifida either. So spina bifida, you may have seen this in 103. So this is when the spine doesn't completely form or it doesn't fuse. And so what happens is this fluid filled kind of lump on the back, between the butt and the back of a baby. And what happens is it impairs the development of the fetus. We know that we can see spina bifida in an ultrasound. And so now surgeons can actually correct spina bifida while the baby's in utero. So before the baby's even born, they do surgery on this unborn baby, sew the mother back up, and let the baby continue cooking, which I think is incredible.
I've seen a video of that.
Wow.
And it looks tiny when they're in a fetus, but when they grow up, you could see a big scar. It's really,
Isn't that incredible?
Yeah.
I think that's
I've seen it.
incredible. Actually, we're really fortunate because the first surgery done on an unborn child was actually in San Francisco at UCSF. So California is one of the best places to go for that. So questions about spina bifida? Children who have this corrected often function normally as well.
That's good.
All right, muscular dystrophy. Muscular dystrophy is typically extremely progressive. The muscles might start off with some strength, but progressively get weaker as the child gets older. Duchenne's muscular dystrophy is the most common type of muscular dystrophy, and it only affects boys. So we see a high percentage of boys with muscular dystrophy over girls with muscular dystrophy because Duchenne's is so common. It is a sex-linked disorder, which means that it comes from the X from the mother. So it is inherited from the mother. The mother is a carrier, so the mother won't show signs of muscular dystrophy, but then will pass down that affected X. Children with Duchenne's muscular dystrophy, you often see this weakness happening proximal distally. Anybody remember 103? I'm going to take you back. What's proximal distal? So proximal, starting from within and then working its way out. And so you'll see first their core start getting weaker, and then you'll see their shoulders start getting weaker, their arms, and lastly, their fingers start getting weaker. And they can live a pretty long life, like 40, 30, 40s, but by the time they're that age, that decrease in the ability to function muscularly, they're pretty much dependent on somebody to take care of them. This is another condition that it's so important to recognize. Children with muscular dystrophy don't have a cognitive impairment. So I worked with one little boy and he had Duchenne's muscular dystrophy. He also had an older brother in his 20s who also had Duchenne's muscular dystrophy, and then a sister without muscular dystrophy. So we know that it was only affecting the boys and not the girls in the family. And he was extremely bright, and you can see the annoyance all over his face when somebody talked to him like a baby. And so he was about 3 years old, and he would walk into the door, and anytime any of the teachers would see him, he was at the lab with us, and so they would say, "Hi, how are you today? Did you have a good weekend?" And he'd look at them and he just would give them the dirtiest look. And he didn't want to talk to them, and he would move. He used a walker in our program, and so he would move his walker to the side and like totally try to ignore them because he was annoyed. Like, don't talk to me like a baby. I'm not a baby. He communicated, he was moving his hands sometimes to communicate, but he had some sounds. He was really working on some of the consonant sounds, but I'll never forget one day we were outside and he saw a dead spider. And so he looked at the spider and he looked at me and he said, "Oh, and he went like this, like, "Oh my gosh, it's dead." I said, "Oh, wow, you found a dead spider, huh? What should we do with it?" And he's like, "Oh," and he's looking around. And I said, "It looks like you might want to bury it. Is that what you're telling me?" And he's like this. So his movements were over exaggerated when he would try. And so, and then the whole day, like he was sad. He was mourning the death of the spider. And so the whole entire day, that's what he wanted to tell everybody. And then he went home. We told his mother what happened and how he was sharing that with us. And then he came back the next day and said, that's all he's wanted to talk about when we got home. All he did was, oh, like he was just thinking about that spider. And then sure enough, that day at school, the first thing he wanted to do was go and check on where we buried the spider. So he wanted to communicate. He actually ended up really loving insects. And so that was something we found out about him. He also loved to engage with other children. I'll never forget, I had him in a group and I had a child with pica in a group. So pica is a condition where children will eat anything. So they put everything in their mouth and they actually ingest it. And so I had this little girl who we were trying to really allow her to use Play-Doh, even though we knew she would eat it. And we were trying to give her other things to do with the Play-Doh. And so what we did was we rolled it up and we put it on her nose. And so she thought that was hilarious. She rolled it up, put it on her nose, and this little boy with muscular dystrophy pointed to the Play-Doh, pointed to his nose, telling us, I want Play-Doh on my nose. So not the teacher, but the other child with pica rolled it up and put it on the little boy's nose, and they both laughed so hard. And it was so beautiful to see this connection between two children who might have otherwise been struggling to connect with other children. So from that day forward, they wanted to hang out together. They wanted to sit at the same table. It was really, really neat to see that relationship progress throughout the semester. So I love that story. It's still it makes my heart warm every time I think about those two. So, questions about muscular dystrophy?
No.
Go on. So there's also hip dysplasia and juvenile rheumatoid arthritis. So hip dysplasia usually occurs in utero. So as the child is developing, either there's not enough space in the womb, or maybe there was some injury. And so what happens is the hips are not fully in the femur is not fully in the hip bone, and so the legs are turned out. So you can see this child right here, and usually what's done here is corrective casting. So this is called the spica cast, and what it's doing is it's slowly bringing in the hips this way so that the child is no longer outward facing but now inward facing. So you see how this is probably not connected properly to the hip socket. So here's your hip socket and here's your thigh bone. And for children with hip dysplasia, the thigh bone is facing this way. Does that help?
Yeah, I have a cousin that her daughter came out like that. And they had her in a cast till like she was 2, I think.
Oh yeah, so spica casts usually stay on for anywhere from 6 months to a year. Mm-hmm. But then once they get out of...
Yeah, she's fine now.
Yep, mm-hmm, they can function typically. Usually they require follow through or follow up from a physical therapist for about a year, but usually they're developing typically. For juvenile rheumatoid arthritis, this is an extremely painful condition. If you know any adults with arthritis, you might know how painful that is, and that can feel. So now think of a young child working through that pain. And a lot of times with children with rheumatoid arthritis, they're in so much pain they don't want to move, which is counterproductive to the condition. We want to get children moving. We want them to not sit in one place for too long because then their joints stiffen. And so really working with them to get some of that exercise, get some of that movement, even if they're in pain, because it will help their pain and support them in not feeling as much pain. Okay, not getting that stiffness. All right. Any questions? Sorry. No. Okay. So what are some program implications? We know that children with physical impairments have the same basic needs as other children. And so a lot of what we're accommodating is the space, is the environment. The services of various pediatric professionals working as a team with teachers. So you'll have an occupational therapist, sometimes you'll have a physical therapist, maybe a child development specialist, maybe a speech pathologist, but all of these professionals are working together to support this child in the program environment. We also know that it might be tempting to say, oh yeah, we had a child with muscular dystrophy before, and we made this adaptation, so we're prepared for all children with muscular dystrophy. That's not true. So each child is going to have their own unique individual needs. So equipment needs to be designed for each child's particular disability. You especially with muscular dystrophy, a lot of times you're adapting equipment to fit their height and their positioning and their skill level. And so that's going to differ from child to child. And of course, those environmental adaptations to facilitate and support each child's learning efforts. So maybe it's the positioning of curriculum, maybe it's their own positioning, looking at how that child can function the most efficiently, okay? All right, like I said before, it is a team effort. So physical and occupational therapists are going to play a huge role in working with children with physical disabilities. These are some of my favorite therapists to work with because they're so knowledgeable. If they're really good, they know how to support teachers and infant development specialists in positioning so that when they leave, we can continue to do some of those exercises with children so that they continue to get therapy within the classroom environment. I also know that even though I've been well trained by physical therapists, I will never do positioning on a child without the support of a physical therapist and without the feedback from a physical therapist, because I never want to move a child in the wrong way and cause more damage than benefits, okay? Children with physical disabilities, because they qualify under the IDEIA, they'll probably already have a family service coordinator who might bring more professionals into the team, like nutritionists, possibly a social worker, the dentist, doctor, and then any other external support systems to support the child and the environment. So this is pretty much what I said. We should never, ever initiate any type of therapy or positioning unless we have a physical therapist's approval. Okay. Questions about this? All right. So let's look at adaptive equipment versus adaptive material. So adaptive equipment, like I said before, it's going to support the child in their movement and their ability to maneuver around their environment. So these can look like things like braces. These are full leg braces, but I also frequently work with children who have AFOs, ankle foot orthosis, and that supports the child in gaining balance when they're standing so that they can take those first steps and walk with more balance. Any walker or wheelchair, so these are things that are usually already created for children with physical disabilities, but there's also things that we have to adjust. So maybe they have braces, but the flooring in your classroom isn't conducive to their braces. So maybe you put something on the bottom of those braces or something to support the child in using their mobility device in your program. There's also positioning devices that I'm going to show you on this next page, but this is an example of a positioning device. These are called prone boards. And often what it does is it supports children and using their arms to move them forward. Okay. So here's some really great positioning devices and examples of adaptive equipment. So what do you think this child is working on right here? He's working on lots of things, but what are some of those things he's working on?
Balance.
Balance, yes. What part of his body specifically on? As far as balance?
Say his top.
His core, yes, his core. So when he's sitting on that, he's having to balance himself so that he doesn't fall to one side or the other. So he thinks he's just sitting down playing with those little bears or whatever he's playing with, but he doesn't know that as he's keeping himself in that central position, he's working that core that's going to strengthen his muscles and strengthen his ability to stabilize. Okay. There's also these wedge boards, and not always do they come with the straps, but straps are something that you can adapt, right? So if you have the wedge, but you don't have the straps, you can create those manually. And what this does is for children who might not be able to move their body or have control of the lower half of their body, it stabilizes the lower half so that they can focus on the upper extremities. Okay, so it kind of isolates these muscles. A power wheelchair device is also an example of adaptive equipment. This is a standing walker. This is another example of things that you can do with a wedge board. So all adaptive equipment. And this child too is focusing on sitting upright and working on that core. Okay. Questions about any of this adaptive equipment?
No.
I work at this school, and we have like also like bikes where you can actually strap the children all in, and they have a handlebar. You could just pull them, and it helps just have them like feel like they are riding the bike even though you're pulling it. But it's just awesome.
And that's a great example of adaptive equipment and something that you can do with a regular bike. I think I have an image. Oh, it's not on here. I thought I had an image of a bike and there was straps on the pedals so that the child's foot would stay stable. And because some of the adaptive equipment that's already made can be really expensive. So when you're in a program on a budget, sometimes you have to make do with what you have, the resources you have available to you. And so this bike just had a handmade strap that stabilized the child's foot to the pedal. And maybe it's a jump rope that you tie to the bike and have other children pull it so that they're then supporting each other in that social interaction. Okay, but that's
really cool.
Okay, so something that will blow people away if you go in for an interview is knowing about UDLs. These are the Universal Designs for Learning. If you bring up that phrase in an interview, you're getting So what UDLs means is that it is our responsibility to design a curriculum, to design a program that's going to meet the needs of every child that walks through the doors. And how we do that through these three principles. So there's multiple means of representation, multiple means of expression, and multiple means of engagement. So when we go through multiple means of expression, we want to make sure that learning takes place in different formats. So if we are just, like if I were just to lecture the whole time and you never got any hands-on experience, that would not be part of the Universal Design for Learning. We also know that we need to provide activities with multiple and varying levels of complexity. So one of my favorite things to do, because it also supports children's social engagement, is let's say you have a manipulatives table and it's puzzles. You're going to put a large knobbed 3-piece puzzle at one chair, and then a small knobbed 7-piece puzzle on the next chair, and then maybe an inset puzzle on the chair across from it. So every chair has differing levels of complexity. And what does that do for when you have a bunch of different children at that table? Who are they learning from?
Each other.
And they just think they're playing, but really they're observing each other. They're seeing how they can do that next step, and they're supporting each other. So it's one of my favorite things to do to engage children socially. We want to also make sure that we are supporting vocabulary. So the way that we are interacting is not limiting what we're saying or simplifying it in order to make things easier. We're making sure we have that same expectation, but we're providing the supports. Okay. Multiple means of expressions. We want to give children a lot of different ways to tell us what they know. If we only test or assess one way, we're only assessing children who are able to express their knowledge one way. And we're missing those children that might not be able to verbally tell us how much they know, but maybe they can draw how much they know. Maybe they can show you what they know. So, for example, I had a child, the child I was telling you about with the Play-Doh, who had muscular dystrophy, and he couldn't tell us verbally that he knew his shapes and knew his colors, but what he could do was, I mean, it took him some time, but he can take a blue bear and he can put the blue bear in the blue cup. Like, he knew exactly how to match these colors, and we knew, okay, you have your colors down, but he couldn't tell us that. But because we were able to assess him in a different way, we knew that he still met that level. Okay, multiple means of engagement. One of the biggest things in this area is we want to model that that's okay for children to make mistakes, that it's okay for them to learn from those mistakes. When we're punitive for children who make errors when they're trying something, that's going to affect their interest and motivation to try something again. And so instead, if we can facilitate their learning through that mistake, they're more likely to try again and again and again, because they realize it's okay if they don't do it right. They can have another chance. They can progress in their ability to do that skill. Okay, so, and this is universal design for learning, is for working with all children. Okay, questions about this? Nope. So when we talk about materials, we're talking about things in the classroom that are used for curriculum, that are typically seen in a classroom environment, and what you're doing is taking that curriculum, taking that material, and adapting it to fit the needs of the child. So these are some really simplistic adaptations. I had a child who had a really hard time holding his crayon. Like, it just would fall through his hand because his hand was stuck in this hypertonicity position. And so what he did like, and what fit perfectly in his hand, was a car. He loved his cars, back and forth, back and forth. So if you melt any crayon and you put them in a mold, they will dry in the shape of the mold. So we just made little cars for him for crayons instead of the skinny crayons, and then he was able to color with everyone else. These are pre-made adaptations. So what happens with the egg is it widens the base. So children that don't have that strong fine motor skill can still participate and hold the crayon like this instead of like this. Okay. This is another adaptation for writing. Anytime you make the base where the child is holding on wider, you're adapting it in order for that child not to have to move their hand in such a fine position. This is a medicine bottle container. Also, hair rollers. So does anybody remember hair rollers, the little sponges?
Yes.
You can also use those, and those really easily just fit right over a crayon, and it's a nice texture, and children can use those as an adaptation as well. Pool noodles, you can see any kind of, this really is interesting because the child can actually stick their hand in this space right here, and then that supports them. Oops, sorry. So there's so many different ways to adapt some of these materials to support the child's fine motor skills. Okay. There's also supports for eating equipment. So if you are hypertonic and you have your movements are over exaggerated, is it going to be difficult for you to eat?
Yes.
Yes, and so the child who tries to scoop something out of the bowl that's not fastened down to the surface, that bowl's going to go everywhere and make it harder for them to bring the spoon back up to their mouth. So these suction devices on bowls are a great adaptation, because what they do is they keep the bowl still and support the child in being more successful. Oh, hey, I did have that picture of the bike.
Yes.
So this is a really great example of an inexpensive way to make really expensive equipment. So this is typically expensive, but what the teacher did was just support the child by stapling on these straps to the board underneath it. This is my best friend, and I love it because it's at the dollar store for a big old roll of it. Does it look familiar to anybody?
It's the things that you put on the bottom of the boards, the cabinet boards.
Yep, they're drawer liners. And so why do you think these are my favorite things? What do the plates do? When you put the plates on the drawer liners, do they move?
No.
So what I do is I put these under anything I want to stabilize. If the child is doing a puzzle, I put it under the puzzle and that puzzle does not move. That way when the child with athetosis is trying to insert the puzzle piece in the puzzle, that puzzle's not moving everywhere. So love this stabilization device, and it's so cheap. So anything that's inexpensive, I'm all about. We also want to make sure that we're spacing furniture apart effectively. So if these were too close together, what couldn't fit through?
A child with a wheelchair.
A child in a wheelchair, exactly. And then here, even lowering or putting material and curriculum up on the wall instead of on a table supports a child who might be in a walker or who might be in a wheelchair that can't be at the table all the time. And so this is a great way to support children in play. Questions about this? All right. So here's some more adaptations to the classroom. We talked about the wheelchair, the space to maneuver. We want clear toileting areas and handrails mounted on the wall for independence. I've seen handrails mounted outside as well using PVC pipe. So these don't have to be expensive equipment and materials. These can be things you buy pretty cheaply. Railings indoor and outdoor to assist children with poor balance. Really paying attention to floor coverings. So carpet is good for children with mobility issues, but it has to be nailed down. We don't want the rugs if you've ever walked on a rug and then it folds,
Yes.
It's a tripping hazard, right? So we don't want the rugs that fold. We want to make sure that rug is securely fastened to the floor. So if there are no carpet and it's linoleum, we want to make sure that any kind of walkers or crutches or shoes that the child's wearing are non-skid. There are ways to make the shoes that they're already wearing non-skid. So we don't want them to just go out and buy new shoes. If you put hot glue on the bottom of shoes and let it dry, what it does is it creates little patches of non-skid markers. So a really easy way to make non-skid shoes. We also want to be aware of transitions. So if we don't want to always dismiss the child with the physical disability first. And we also don't want to dismiss them last and have it take 10 minutes by the time they get up to their small group table. The activity's already midway through. But if we dismiss them first all the time, then you're having to deal with some of the social repercussions, right? So why do they always get to go first? So we want to time their dismissal appropriately, okay? And we are done. Any questions?
No.
Okay, I'm gonna go ahead and stop the recording.